do I have any suggestions about how to be more time efficient in keeping both psychotherapy notes and medical records? There are a couple of technical ways. Let me give you my own solution. I don't try. I actually have one set of records, and I use the old saw that most of the time clients are eventually going to get to see my record even if I object to it. So I should be writing records with the client on one shoulder and a not particularly happy attorney on the other, and brief and behaviorally descriptive, and that this is not a place for me to go into my, kind of questioning the dynamics of a client. I definitely need to think about that, but it's not going to be a therapy record in general. Okay, so my own that since I have a tough enough time keeping one record, I'm going to stick with one. But there are some solutions that you can use on computer that actually are a nice way of there are some programs that allow you to keep two different records, and essentially what they do is you fill in the standard medical record for every session, and much of it's routine or automated. So if you open up the particular screen on a given day to enter in for a record for Ms. X, your client, or it pops up, it gives you the date already. You just click on the time that you saw them. You click on the whether it's a group or individual or family session, co-joint session, and a number of things of what you would have a list. The treatment goals and objectives and problems. You might just for those of us in private practice, oftentimes what seems to be required in a record doesn't seem to make much sense. For example, one may not have a diagnosis that changes every week, and if you're seeing somebody for 5 years or so, it can be really silly to enter every single week what the diagnosis is. And so the question was, what really is the minimum amount of information that can be kept in a record? And by the way, I think this dovetails with the previous question in that if you use some of the more automated record-keeping systems, they will automatically forward the information that you don't want placed in fields in your current record for today, so you don't have to reinvent the wheel. So for example, while you might not change your diagnosis, maybe, for example, it's 6 months later and the person no longer carries a diagnosis of a generalized anxiety disorder, and that's what you've been working on, and that means it's been a successful treatment. You change it once in 6 months. If you're not automated, then there's some basic information that you want in any kind of record that you keep. And I'll kind of start from the top and tell you what I think is kind of crucial. When you're doing your initial intake, your initial contacts, it's very important to have identifying information in a document. You want to describe in writing a presenting problem, what the person is coming to you for. Document that you've asked a question about whether there's a crisis or emergency. And then obviously, if there is one, you will take a whole series of steps and document about that. But under the more typical circumstance, you will say, ask question about whether there was homicidal ideation or suicidal ideation or any emergencies ongoing, and the client reported none. Okay, something along those lines. and whether you've made an appointment or made referrals, and if so, to whom. Okay, so that's, and I actually, even when you make referrals, it's very good to have a file, a chronological file that will give you a record of over the past year. You know, say you've been fortunate enough to have 78 referrals over the past year, and you've had to refer them on in about 15 or 20 cases. Well, just having a very brief documentation of this information for the person who you've done an intake for and referred is helpful if it turns out that they later complain somehow you didn't provide appropriate services and you weren't in fact a provider. Okay? You never did. You just made a referral and they were to 3 people who you thought were appropriate. We need an informed consent form typically. Now, there was a very useful, I think, publication in the summer, it was the spring or summer Board of Psychology update. Bram Friedhandler and a group of his colleagues at CPA put together a kind of expert series practice recommendation. And in that practice recommendation, they said we have to document informed consent, but we're not required to do an informed consent form. And I think that that's true, and it allows us more flexibility depending on the type of services that we're doing. But if you're doing a private practice, outpatient clinic, outpatient work, and even if you're working with very high functioning folks, or if you're working doing long-term psychoanalysis in its classic form, my sense is it's very wise to do an informed consent form, both from the perspective of the ethical dimensions, legal dimensions, and also, although it certainly, there's lots of debate within the analytic community, certainly in structuring the treatment relationship in a way that's very clear. But there are circumstances where you're not going to use an informed consent form. And that might include, for example, those of you who work in a medical setting and you do behavioral medical consultations. You're basically asked by a physician to show up in a patient's room for a 20-minute consult. If you did a whole informed consent form, you'd spend your whole time doing informed consent, and you'd never do your assessment. So a verbal informed consent that describes the basic dimensions of what kind of relationship you're going to have, why you're there, the assessment, and who's going to hear about it. You give that information and you make sure you document it. So you notice the circumstance kind of governs how you document the informed consent process. If you're going to do an outpatient service, it's very wise, I think, when you do an intake to document that you've asked about drug and alcohol use. It's good to ask about legal history, if the person's coming in with any child abuse history. I thought for a while that the whole debate about recovered memories had pretty much died out, but it has flared up again, as you could tell from the webcasted lecture and the Dow versus Loftus case. And any current and previous kind of family relationships that are critical to the person and that you might need to know about. We talk about contacting the family members if this person is suicidal, and also is somebody considered an immediate family member for the purposes of Tarasoff. Where there's a rule that says, there's an old case that says that we should be getting all previous records from prior psychotherapies. I frankly don't know any psychotherapists out in the community who get all previous records, because often those records are unavailable, they're old. So that's one of the things that's suggested. I think it's really worthwhile to document that you've made some kind of attempt to get access to previous records and what the result of that attempt was. And then in terms of the kind of services that we're providing, it's very useful in terms of a document to have at least some basic treatment planning information. What are you doing? What's the definition of the problem? Identifying information, the goals and objectives, kind of baseline functioning for your client, however you might evaluate that, and then the specific types of treatment that you're recommending. The more particular or the more descriptive you are at the outset, the easier the record keeping later. So for example, if you're doing a dynamically oriented work where a person has come in and is struggling in their relationships with other people, and what you determine in the first few sessions is that this is a person with some fairly intense Oedipal conflicts, and you say so. And while you may also give a DSM-4-TR diagnosis, maybe it's going to be a V code because it's primarily relationship related, and classic types of interventions around that sort in the context of doing analysis are confrontation, interpretation, and so on. And so one might list those types of interventions. If you're doing a cognitive behavioral type of therapy and a person comes in with an anxiety disorder or trauma, similar kind of idea. And then in terms of the day-to-day, obviously the name and date of the service, what you're doing, is it individual? And again, you can do for this because if it's just redundant, you would just do I for individual, or you maybe would create a form for yourself and check it off. If you want, one line perhaps about the goals and objectives that you were addressing in this particular to finish talking about what I think should be in a record for psychotherapy, and on that weekly record in particular, in addition to what kind of goals and objectives you had for that week, and then the narrative, you can meld the two, and then we have a signature. If there is an incident or a crisis that happens that week, you want to document that very carefully. I have a particular format that I use that I have borrowed from Bruce Bonger and Eric Harris that I think is a very nice way of capturing what we should write about when there's an incident. But if there's no incident and there's no crisis going, very good idea to note that in your one way or another. I typically, in every single session that I do, what gets included is no crises reported or no emergencies. One of my colleagues has two boxes. One says, any crisis or emergency, yes or no, and checks off no. And so you want to have some documentation, and let me explain why. Even if you've had wonderful luck so far, 30 years of practice and nobody's ever been terribly problematic, wonderful. It only takes one client who alleges that they said to you in a session that they were experiencing a lot of suicidality, and then in your record it doesn't say anything about it, but it also doesn't say about whether there were any emergencies or crises. And so this is a pretty important piece of information to have, even if it may be only important once or twice. It makes the difference between being able to adequately defend oneself, not just legally, but ethically, in terms of the standard of care that we've. And it also is good to have a record of that when we have a client who has a fair frequency, a fairly high frequency of emergent situations. We can make our clinical judgments based in part upon how many yeses we're getting about crises. Is this person really appropriate for outpatient services? Am I the person who should be providing it to them, and should I be ending treatment? We want to have a signature. You can have an online signature, by the way. And we also should have a discharge note. Now, I realize that's a lot of information, and I realize also that for, kind of from a professional perspective,